Next topic is brain metastasis. And honestly, not much the research has been going on for patients with brain metastasis. This is a picture of the patient with the brain metastasis. Side view of the brain. We can see, probably anybody can tell there's some abnormalities going on here. Big lesions, number of lesions. In the view they're looking at straight cross section of the brain, we can see big lesions. And midline has shifted to the side, causing swellings, causing the patient's symptoms, headaches, nausea sometimes. And in general, the common type of melanoma is called parenchymal. Basically means tumors involving the melanoma, the brain tissue itself, just like what you see here. Symptoms, headaches, weakness, patient may have altered mental status, so confusions, very sleepy more than usual. Patient can have, it's like stroke-like symptoms. Sensation is different. The motor, the muscle weakness happens. Seizure can happen. But sometimes patient has no symptoms whatsoever, but they found melanoma lesions in the brain. Usually CT scans, MRI scan can be a diagnostic for this brain metastasis lesions finding. And if not sure, not caused either melanoma, other type of cancers, or even infections, sometimes you need biopsies. There's a certain subset of patients that developed probably even worse disease called leptomeningeal disease, involving the brain's space, but basically involves the membrane of the brain, and that causing the tumor cells spread into the brain fluid that communicates with the brain fluid and spinal fluid. Symptoms can be somewhat similar: weakness, confusions, lethargy, stroke-like symptoms, nausea, dizziness can happen with it. And MRI scan is probably diagnostic of it, but some patients may need lumbar puncture, also called spinal tap, to prove there's melanoma cells in the brain and spinal fluid. Management, once again, is quite difficult. Brain metastasis is quite commonly happens in patients with a metastatic disease. In different reports, mention about 10 to 50% of the patient with advanced melanoma has brain involvement. In fact, in autopsy series, even 60 to 75% of the patients actually are found to have brain metastasis. And many patients with the brain conditions will die of the brain-related issues or neurological symptoms. Surgery can be done in some patients. If lesions are small in numbers, maybe 1 or 2 at most, superficial towards the outside of the brain, sometimes you can do surgery. But we are talking about small number of patients because many patients develop brain lesions deep inside or multiple number of lesions. Also, the whole brain radiation therapy can be performed sometimes. And main purpose is the palliations. If patient has symptoms from this brain metastasis, radiation therapy can sometimes help patients. But so far, there's no evidence radiation therapy can improve survival or prolong survival. So in general, overall survival is not very good. So a number of the reports of the patients of the brain metastasis mention somewhere between 3 to 4 months in general. Patient who gets a gamma knife procedure, cyber knife, or stereotactic surgery in limited number of lesions, sometimes it can be well controlled, but it doesn't guarantee to prevent recurrence in elsewhere. Median overall survival after gamma knife, usually 5 to 6 months, and once again, these are the somewhat selected patients who may qualify for the gamma knife procedure. In terms of chemotherapy or systemic treatment, nothing that we know that has very effective in brain metastasis. And temozolomide has been used a lot for patients with brain metastasis because these medications, chemotherapy, can cross so-called blood-brain barrier between blood vessels and tumors, but yet response rate not very good. This is our experience with the brain metastasis. Patient with brain metastasis, 330 patients were observed. This is the survival curve, meaning that most of the patients, almost more than 80% of the patients, do not live more than 12 months. There's a small subset of patients, probably about 5% or so, who can live beyond 3, 4, 5 years with the brain metastasis, but they're not the majority. Patient looking at 1996 or before, or patient diagnosed after 1996, There's some improvement in overall survival, but nothing significant. So this dotted line here shows the time of the patient following after 1996. Slight improvement, but yet most of the patients do not make 1 year of survival. Patients with more number of lesions in the brain, the worse. 1 lesions tend to be better. This graph shows, once again, leptomeningeal disease that involves the brain fluid involvement, has even worse prognosis than brain metastasis. In general, overall survival, we quote about 6 to 8 weeks of survival in general. Over the years, different part of the world did systemic treatments for patients with brain metastasis, different agents, which may cross blood-brain barrier, which may be able to reach the brain, but yet response rate, significant tumor shrinkage happens very rarely. And the available information is 20%, but the repeat of the same study didn't show much of promise. So in general, systemic treatments, chemotherapy, even radiation therapy combinations, not very favorable in general. This is the patient who had BRAF mutations and received BRAF inhibitors. Patient with a number of lesions, you can see in the yellow circle, some lesions here, number of lesions. After 4 weeks of treatment, some improvement, but after more than 2 months of treatment, most of the lesions are gone. So maybe some of this new target therapy may be more efficacious in the brain. This occurred during the phase 1 clinical study of a drug called dabrafenib, BRAF inhibitor. So encouraging results. So let's go with the larger studies. The phase 2 study was conducted. This is the result of the study. Patient has to have BRAF mutations, of course, and patient has to have active disease, at least 0.5 centimeters lesions, up to 4 centimeters. That was the limit of tumors to be eligible for the study. And patient, this is the graph, patient who doesn't have any symptoms, no steroid use, no symptoms, and get this treatment. This is the result. About 38% of the patient had overall tumor shrinkage all throughout the body. If you're looking at the brain itself, it's the intracranial response rate, meaning that the response was very matching close to the other part of the body, 39% versus 38%. So it's kind of surprising result because we always thought, the treatment doesn't work in the brain as well as the other part of the body. But this study has shown that maybe that's not the case. Maybe even brain metastasis we can do something about. And this is an example of actually large lesions in the brain. Everybody can see it. And after 32 weeks of treatment, 8 months of treatment, pretty much all shrinkage of tumors has been documented. Encouraging. So this study of the dabrafenib, this is the first systemic treatment clinical study. They shows that actually this clinically meaningful benefit can be there with a systemic treatment, even without radiation therapy or surgery. And once again, response rate, tumor shrinkage happens as good in the brain as well as other part of the body. And in general, this treatment was safe. The number of the severe side effects was not very much. There's 2% of the patient died in the clinical studies. We think it's probably because of the tumor got worse over time, not because of the treatment effect itself. So with this information, maybe this is time that we think differently how to approach the brain metastasis. Maybe not the radiation therapy to start with, some type of systemic treatment, chemo or target therapy may be more efficacious. Dr. Schnell mentioned about anti-CTLA-4 antibody, immune therapy called ipilimumab. There are some also signals of improvement in the brain with ipilimumab. So a formal phase 2 clinical study was conducted, patient with active brain metastasis. Patient received a little higher dose than usual. The usual dose of ipilimumab, so-called Yervoy, is about 3 milligrams per kilograms. In this clinical study, patient received 10 milligrams per kilograms every 3 weeks as usual for 4 times. But patients doing well, disease under control by 6 months, they are allowed to continue as maintenance every 3 months of the treatment. There are 2 cohorts of patients. One cohort, patient without any symptoms, patient doesn't require any medications for brain, they were enrolled. Cohort B are the patient with the symptoms, headaches, they have some kind of a weakness, or patients who required steroid to control the symptoms were enrolled. The response, tumor shrinkage, occurred about 16% in the brain. There's two different ways of measuring the response, but in general, about 16% of the patient had tumor shrinkage in the brain in significant manner. Although complete shrinkage didn't happen that often, there's no complete responses. Patient with symptoms, who need steroid or symptoms, they tend to have larger tumors, so their response not as good as the patient without symptoms. About 5% of the patient has some regression there. If you're looking at progression-free, how long did it take before tumor get worse, is about 2.7 months with a patient with a Cohort A, asymptomatic patients. Not a great number, but still we think it's better than the chemotherapy itself. Once again, this is not randomized between chemotherapy and immune therapy, just everybody gets immune therapy itself. So we may need more further confirmation studies to say this actually is better than chemotherapy. Overall survival, historically, we mentioned about maybe 4 months, 5 months of survival, but patient with without symptoms has 7 months of survival on this clinical study with ipilimumab. Patient with the severe symptoms or who require steroids, only about 3.7 months of the survival in this case. So patient with the big tumors, the ipilimumab treatment may not be too efficacious in general, but if you find it early, patient doesn't have any symptoms, maybe this is reasonable to consider. Once again, the reason for using ipilimumab is not that we're going to improve survival on everybody, but some of the patients can have a prolonged survival and durations. That's the reason why. Side effects, in general, it's not too bad. Some side effects happen about 35% of the patients, but severe side effects, like severe headaches, only happen about 4% of the patients. So in general, it's not that harsh to get this treatment. So now we have some evidence. Immune therapy, target therapy may have effect on the brain metastasis. But once again, most clinical studies, if patient has active brain metastasis, they're excluded from the getting into a clinical study. Certainly need more treatment and trials for these patients. And our colleagues, Dr. Davis in our department, is interested in brain metastasis, trying to find what's happening in the brain. Why is it different than other part of the body? One of the main things he found, is that protein called AKT. This is different protein, different pathway than BRAF or MEK. That's more important and plays more roles in the brain compared to the other part of the body. So if you look at patient with the tumor samples and look at pathology slides, we can certainly see this protein called AKT is more activated with the brown stains compared to the patient with the lung metastasis. In fact, the same patient, so how tumor looks is different in the brain and the lungs. So we may need to consider some kind of a target therapy against protein called the AKT or these pathways in patients with brain metastasis. And we are going to have some clinical studies of the blocking that pathways to see if that strategy will work in the brain. So future directions. The brain talk is a little small because of, once again, lack of research in the brain metastasis. We certainly need better and larger number of clinical studies who can include patients with the brain metastasis, who can learn about this. And there's a number of trials, including BRAF plus MEK inhibitors that we talked about earlier, combinations in patients with the brain metastasis. Also, once again, patients with the BRAF inhibitors plus AKT inhibitors, where the pathway blockage is something very interesting we are considering in the next few years. The drugs that can penetrate this barrier called blood-brain barrier, so more drugs can go into the tumors, will be very important. So drug companies are involved in developing new, better medications, more efficacious medications. Maybe even future chemotherapy may work in the case as well. So we'll see how it happens in the next few years. And we have to understand some biology of melanoma in the brain. The AKT protein we just mentioned is one of the examples, but I'm sure there's a lot of other things happening in the brain we have to know more about. And the clause called personalized medicine, personalized therapy for cancer can be potentially applicable in patients with brain metastasis. If patient has BRAF mutations, maybe patient can get BRAF inhibitors plus something else, maybe MEK inhibitors, AKT inhibitors, and so on. Or patient without any mutations, some of the immune therapy like ipilimumab can be beneficial in some patients. And with AKT playing a role in brain metastasis, certain new target therapy targeted may be important. And even more, possibly more promising can be anti-PD-1s. And we know about how promising the anti-PD-1 antibody is. And there's no data at this moment how this works in the brain. And next big thing will be how this treatment works in the brain, how good it is that we're going to find out in the next few years. So with this, I'll conclude my talk on brain. And once again, I'll answer some of the questions if you have at the end of the session. Thank you.